Welcome back everyone. Today we start our lecture with table 18, the aortic stenosis. Keep in mind that table 18 is long. Maybe it will take today's whole lecture or less. Let's begin with aortic stenosis, one of the most common valvular diseases encountered in clinical practice. The hallmark of aortic stenosis is obstruction to blood flow from the left ventricle into the aorta during systole, producing the characteristic crescendo-decrescendo systolic ejection murmur, often preceded by an ejection click in congenital diseases, as illustrated at the top of table 18. Etiology. The major causes include congenital bicuspid or unicuspid aortic valve, degenerative calcific diseases due to aging, and rheumatic heart disease. Degenerative calcification is the leading cause in older adults, while bicuspid valves are the most common causes in younger patients. Disease staging. As shown in table 18, aortic stenosis progresses through 4 stages. Stage A represents patients at risk, usually with congenital abnormalities or valve sclerosis. Stage B includes mild to moderate disease that remains asymptomatic. Stage C is severe stenosis but is still asymptomatic. Patients may have preserved or reduced left ventricular function. And finally, stage D is symptomatic severe aortic stenosis, characterized by symptoms such as angina, syncope, or heart failure. Pathophysiology. The narrowed valve creates left ventricular outflow obstruction. This increases left ventricular pressure, leading to increased end diastolic pressure, concentric left ventricular hypertrophy, progressive ventricular stiffness, reduced coronary perfusion, and eventually heart failure. Symptoms include, remember, the classic triad: angina, syncope, and heart failure with exertional dyspnea. Patients may also experience fatigue, orthopnea, paroxysmal nocturnal dyspnea, peripheral edema, reduced exercise tolerance, pre-syncope or syncope. On physical examination, findings are highly characteristic. Patients have narrow pulse pressure, pulsus parvus et tardus, delayed carotid upstroke, and sustained apical impulse. On auscultation, there's a crescendo-decrescendo systolic ejection murmur radiating to the carotid arteries. Additional findings may include soft or absent A2, paradoxical splitting of S2, fourth heart sound, late S2 in advanced disease. Investigations. According to the table 18, investigations include ECG demonstrating left ventricular hypertrophy, left atrial enlargement, left bundle branch block, or atrial fibrillation. Chest X-ray may show post-stenotic dilation of the ascending aorta, calcified valve, cardiomegaly, or heart failure. The gold standard investigation is transthoracic echocardiography, which evaluates valve morphology, valve area, pressure gradients, left ventricular function, disease severity, and timing of intervention. Additional tests include dobutamine stress echocardiography, CT calcium scoring, and exercise testing in selected asymptomatic patients. Let's move on to management. Management depends on disease's stage. Patients should receive cardiovascular risk reduction and treatment of hypertension. Asymptomatic patients are monitored with serial echocardiography while avoiding excessive exertion. Symptomatic severe aortic stenosis requires valve replacement. Procedural options. As summarized in Table 18, options include surgical aortic valve replacement or SAVR, preferred in younger patients with longer life expectancy or when transcatheter replacement is unsuitable. Transcatheter aortic valve replacement or TAVR is preferred in older adults, especially those over 80 years or those at high surgical risk. Balloon aortic valvuloplasty is mainly used as a temporary bridge before definitive valve replacement. Now let's move to the second half of Table 18, which discusses aortic regurgitation. This condition occurs when the aortic valve fails to close completely, allowing blood to flow backward from aorta into the left ventricle during diastole. The phonocardiogram demonstrates the classic early diastolic decrescendo murmur. Etiology. The causes can be divided into diseases of the aortic root and diseases of the valve itself. Supravalvular causes include Marfan syndrome, aortic root dilation, atherosclerosis, aortic dissection, connective tissue disorders. Valvular causes include congenital bicuspid valve, infective endocarditis, and large ventricular septal defect. Acute regurgitation may result from aortic dissection, trauma, prostatic valve failure. The pathology. The pathology is that the blood causes volume overload of the left ventricle. Over time, this results in the left ventricular dilation, increased stroke volume, wide pulse pressure, high systolic pressure, low diastolic pressure, increased wall stress, and eventually eccentric hypertrophy and heart failure. The low diastolic pressure also reduces coronary perfusion. Symptoms. Patients often remain asymptomatic for many years. As ventricular dysfunction develops, they experience exertional dyspnea, orthopnea, paroxysmal nocturnal dyspnea, fatigue, angina, and syncope. Symptoms usually indicate progression to left ventricular failure. On physical examination, several classic signs are highlighted in Table 18. Patients may have water, hammer pulse, wide pulse pressure, hyperdynamic displaced apex beat, Hill sign with higher leg than arm systolic blood pressure. On auscultation reveals an early diastolic decrescendo murmur, best heard along the left sternal border. The murmur is best appreciated with the patient sitting forward at the end of expiration. Additional findings include soft S1, absent A2, late S3. Investigations include ECG showing left ventricular hypertrophy and left atrial enlargement. Chest X-ray may reveal cardiomegaly and dilation of aortic root. Echocardiography is the most important imaging modality for assessing severity of regurgitation, valve anatomy, aortic root dimension, left ventricular size, left ventricular systolic function, and timing of surgery. When echocardiography is inconclusive, transesophageal echocardiography, cardiac MRI, CT, or cardiac catheterization may be performed. Exercise testing may also help evaluate functional capacity. Management. Medical therapy focuses on reducing afterload using vasodilators such as Ace inhibitors, nifedipine, hydralazine. Patients should also receive treatment for heart failure when indicated. Surgical options. As shown in Table 18, surgery is recommended for symptomatic severe aortic regurgitation, asymptomatic severe regurgitation with left ventricular function, patients undergoing other cardiac surgeries. Available procedures include aortic valve replacement, valve repair in selected patients, and the Bintel procedure, which replaces both the aortic root and the aortic valve when root diseases present. To summarize this page, aortic stenosis is a pressure overload lesion producing concentric left ventricular hypertrophy and the classic triad of angina, syncope, and heart failure with a crescendo-decrescendo systolic murmur. Definitive treatment is SAVR or TAVR. Aortic regurgitation is a volume overload lesion causing left ventricular dilation and a wide pulse pressure with an early diastolic decrescendo murmur, and the treatment focuses on afterload reduction and timely valve surgery before irreversible left ventricular dysfunction develops. Understanding the differences between these two lesions, their pathophysiology, characteristic murmurs, physical findings, investigations, and indications for the intervention is essential for both clinical practice and the MCC QE examination. Mitral stenosis. Starting with the left side of the table, mitral stenosis. Etiology. Looking at the first row of the table, the most common cause is rheumatic heart disease. Other causes include non-rheumatic calcification and congenital mitral stenosis. Definition. The table defines severe mitral stenosis as a mitral valve area less than 1.5 square centimeters and diastolic pressure, half time of 150 milliseconds or more. These echocardiographic measurements determine disease's severity. Pathophysiology. Moving to the pathophysiology section of the table, mitral stenosis creates a fixed obstruction between the left atrium and left ventricle. This leads to increased left atrial pressure, left atrial enlargement, pulmonary venous congestion, pulmonary hypertension, and eventually congestive heart failure. Symptoms worsen with atrial fibrillation because atrial contraction is lost, with tachycardia because diastolic filling time shortens, and during pregnancy because circulating blood flow increases. Symptoms as listed in table, patients commonly present with shortness of breath on exertion, orthopnea, fatigue, reduced exercise tolerance, palpitations, and peripheral edema. Patients with severe disease may develop the characteristic malar flush and pinched facial appearance. Physical examination. The physical examination section highlights several important findings. Patients may have atrial fibrillation, left parasternal left palpable diastole thrill. The hallmark oscillatory findings are loud first heart sound, opening a snap after the second heart sound, low pitched mild diastolic rumbling murmur, heard best at the apex using the bell with the patient in the left lateral decubitus position. Notice The phonocardiogram shown above the table, it demonstrates the opening snap followed by the diastolic murmur, which is characteristic of mitral stenosis. A shorter interval between the second heart sound and the opening snap indicates more severe stenosis. Investigations. The investigation section summarizes the diagnostic workup. ECG may show atrial fibrillation, left atrial enlargement, right ventricular hypertrophy, right axis deviation. Chest X-ray may reveal left atrial enlargement, pulmonary congestion, mitral valve calcification. Echocardiography is the investigation of choice because it evaluates valve anatomy, valve area, hemodynamics, severity, and presence of left atrial thrombose. Exercise testing and cardiac catheterization are reserved for selected patients. Treatment. Treatment focuses on relieving symptoms. The table recommends treating atrial fibrillation, treating heart failure, slowing the heart rate using beta blockers or digoxin, and anticoagulating patients with rheumatic mitral stenosis and atrial fibrillation using vitamin K antagonists. Invasive options. Finally, the table outlines intervention. Percutaneous mitral balloon commissurotomy or PMBC is preferred in symptomatic patients with severe rheumatic mitral stenosis who have favorable valve anatomy and no left atrial thrombose. If balloon commissurotomy is unsuitable or unsuccessful, mitral valve surgery, including repair or replacement, is indicated. Mitral regurgitation. Now, let's move to the right side of the table, which summarizes mitral regurgitation. Etiology. The table lists many causes. Primary causes include mitral valve prolapse, congenital cleft leaflet, infective endocarditis, and rheumatic disease. Other causes, myxomatous degeneration, chordal rupture, papillary muscle rupture, and mitral annular calcification. Secondary causes result from the left ventricular diseases such as dilated cardiomyopathy, myocarditis, heart failure, and ventricular aneurysm. Definition. The table defines mitral regurgitation as a backward leakage of blood from the left ventricle into the left atrium during systole. It may be primary due to valve disease or secondary due to ventricular dysfunction. Pathophysiology. According to the table, regurgitation causes reduced forward cardiac output, increased left ventricular pressure, increased left atrial pressure, progressive dilation of both chambers, and pulmonary hypertension. Symptoms. Symptoms listed include dyspnea, orthopnea, paroxysmal nocturnal dyspnea, palpitations, peripheral edema, and reduced exercise tolerance. Acute mitral regurgitation presents with a sudden pulmonary edema and hemodynamic instability. Physical examination. The physical examination section notes that hyperdynamic displays apex beat, left parasternal left, and apical thrill. The characteristic murmur is a holosystolic murmur heard at the apex that radiates to the axilla. Patients may also have third heart sound, mid-diastolic rumble, and a loud pulmonary component of the second heart sound if pulmonary hypertension is present. The phonocardiogram above the table illustrates the holosystolic murmur, extending throughout systole which is classic for mitral regurgitation. Investigations. The investigation section includes ECG showing left atrial enlargement and left ventricular hypertrophy. Chest X-ray showing left atrial enlargement and pulmonary venous hypertension. Echocardiography evaluates cause, severity, left ventricular function, pulmonary artery pressure, valve anatomy, vegetation, and papillary muscles. Transesophageal echocardiography provides additional detail when transthoracic imaging is inadequate or before intervention. Treatment. For acute mitral regurgitation, immediate stabilization with vasodilators and mechanical circulatory support may be necessary before urgent surgery. For chronic diseases, the table recommends guideline-directed heart failure therapy when left ventricular dysfunction is present. Intervention. The table lists surgery for patients with acute severe mitral regurgitation, symptomatic severe disease, left ventricular systolic dysfunction, progressive ventricular enlargement, pulmonary hypertension, and declining exercise capacity. Procedural options. Mitral valve repair is preferred over replacement whenever possible because it preserves ventricular function, lowers the risk of infective endocarditis, and often avoids lifelong anticoagulation. Valve replacement is performed when repair is not feasible. For selected high-risk patients, the table also highlights transcatheter edge-to-edge repair, abbreviated form is TER, as a minimally invasive alternative. To summarize this page, this table highlights the fundamental differences between these two mitral valve diseases. Mitral stenosis is an obstructive lesion caused primarily by rheumatic disease and is characterized by an opening snap with a diastolic murmur. In contrast, mitral regurgitation is a volume overload lesion caused by failure of valve closure and is characterized by a holosystolic murmur radiating to the axilla. Echocardiography is the cornerstone of diagnosis for both conditions, while intervention is recommended once symptoms develop or ventricular dysfunction appears. This comparative table is an excellent summary for examination preparation because it presents the two diseases side by side, allowing you to quickly compare their causes, clinical features, investigations, and management. Tricuspid stenosis. Let's begin with the tricuspid stenosis. As shown in Table 18, tricuspid stenosis is an uncommon valvular lesion, most commonly caused by rheumatic heart disease. Other causes include congenital abnormalities, carcinoid syndrome, fibroelastosis, autoimmune immune disorders, atrial myxomas, blunt trauma, metastatic diseases, and drug-associated valvulopathy. In rheumatic diseases, it is frequently associated with mitral stenosis. Tricuspid stenosis is the narrowing of the tricuspid valve resulting in obstruction of blood flow from the right atrium into the right ventricle. Pathophysiology. Obstruction causes increased right atrial pressure, leading to right-sided heart failure. Cardiac output becomes reduced and remains relatively fixed during exercise, explaining exercise intolerance. Symptoms. Patients commonly present with peripheral edema, fatigue, and palpitations. Physical examination. Characteristic findings include prominent A waves in the jugular venous pulse, positive abdominojugular reflex, cosmal sign, a low-pitched diastolic rumble heard along the left lower sternal border. Investigations. According to Table 18, ECG may demonstrate right atrial enlargement. Chest X-ray shows right atrial enlargement without pulmonary artery enlargement. Echocardiography is the diagnostic investigation of choice. Cardiac catheterization reveals a large right atrial wave and a diastolic pressure gradient across the tricuspid valve. Cardiac MRI evaluates right ventricular size and function. Treatment. Treatment includes careful diuretic therapy for symptomatic congestion, avoiding excessive preload reduction, treatment of the underlying cause, and heart rate control when appropriate. Surgical management. Surgery is usually performed together with other cardiac procedures, particularly mitral valve surgery in rheumatic disease. Surgical options include balloon valvotomy, valve repair, valve replacement when necessary. Generally, surgical intervention is preferred over percutaneous balloon commissurotomy. Tricuspid regurgitation. Next, we'll discuss tricuspid regurgitation. This condition is far more common than tricuspid stenosis. Etiology. As outlined in Table 18, the most common cause is right ventricular dilation, leading to functional tricuspid regurgitation. Other causes include infective endocarditis, particularly among intravenous drug users, rheumatic diseases, device-related injury, congenital abnormalities such as Epstein anomaly, pulmonary hypertension, right ventricular infarction, dilated cardiomyopathy, annular dilation, carcinoid syndrome, trauma, and radiation. Tricuspid regurgitation is the backward leakage of blood across the tricuspid valve during systole. It may be primary or secondary. Pathophysiology. Right ventricular dilatation produces tricuspid regurgitation, which further enlarges the right ventricle, creating a vicious cycle that eventually causes right-sided heart failure. Symptoms. Patients may develop peripheral edema, fatigue, palpitations, shortness of breath on exertion, and ascites. On physical examination, typical findings include elevated jugular venous pressure with prominent CV waves, positive abdominojugular reflux, a hollow systolic murmur at the left lower sternal border. The murmur becomes louder during inspiration, known as Carvalho's sign, and the left parasternal left due to right ventricular enlargement. Investigations. According to Table 18, ECG may reveal right atrial enlargement, right ventricular hypertrophy or atrial fibrillation. Chest X-ray demonstrates enlargement of right atrium and right ventricle. Echocardiography confirms diagnosis, assesses severity, right ventricular function, interior vena cava size, pulmonary artery pressure, and left-sided valve disease. Hemodynamics assessments with cardiac catheterization may be required in selected patients. Treatment. Management focuses on diuretics to reduce congestion, treating the underlying cause of right heart failure, managing pulmonary hypertension or left-sided valve disease. Surgery. Surgery is recommended for severe tricuspid regurgitation, especially when patients are undergoing left-sided valve surgery. The preferred operation is tricuspid annuloplasty, while valve replacement is reserved for selected patients. Pulmonary stenosis. Moving to the lower section of Table 18, we have pulmonary stenosis. Etiology. Pulmonary stenosis is usually congenital. Less common causes include rheumatic disease and carcinoid syndrome. Pulmonary stenosis refers to narrowing of pulmonary valve, obstructing blood flow from the right ventricle into the pulmonary artery. Physiology. The obstruction increases right ventricular pressure, resulting in right ventricular hypertrophy and progressive right-sided heart failure. Symptoms. In symptoms, patients may experience chest pain, syncope, fatigue, peripheral edema. On physical examination, key findings include a systolic ejection murmur at the second left intercostal space, increased intensity during inspiration, pulmonary ejection click, and right-sided fourth heart sound. Investigation. As summarized in Table 18, ECG shows right ventricular hypertrophy. Chest X-ray demonstrates prominent pulmonary arteries and right ventricular enlargement. Echocardiography confirms the diagnosis and assesses severity. Treatment. Patients with severe or symptomatic pulmonary stenosis undergo balloon valvuloplasty, which is considered first-line therapy. Surgical options. If balloon valvuloplasty is unsuitable or unsuccessful, surgical valvotomy may be performed. Pulmonary regurgitation. Finally, let's discuss pulmonary regurgitation. Causes include pulmonary hypertension, infective endocarditis, rheumatic disease, repaired tetralogy of Fallot, defective valve coaptation, annular dilatation, and fibrosing disorders. Pulmonary regurgitation is the incomplete closure of the pulmonary valve during diastole, allowing blood to flow backward from pulmonary artery into the right ventricle. Pathophysiology. The resulting volume overload increases right ventricular wall tension, leading to right ventricular hypertrophy and eventually right-sided heart failure. Symptoms. Patients may complain of chest pain, syncope, fatigue, and peripheral edema. On physical examination, characteristic findings include an early diastolic murmur along the left sternal border. When pulmonary hypertension is present, a high-pitched Graham-Steele murmur heard at the second and third left intercostal spaces, and the murmur becomes louder during inspiration. Investigations. According to Table 18, ECG demonstrates right ventricular hypertrophy. Chest X-ray may show enlarged pulmonary arteries and pulmonary hypertension together with the right ventricular enlargement. Echocardiography confirms the diagnosis and evaluates severity. Treatment. Most patients require only treatment of the underlying condition. Valve replacement is rarely necessary but may be indicated in severe symptomatic diseases with progressive right ventricular dysfunction. Surgical option. The definitive surgical treatment is pulmonary valve replacement. To summarize this page, tricuspid stenosis causes obstruction to right ventricular filling and leads to elevated right atrial pressure. Tricuspid regurgitation is most commonly functional due to right ventricular dilatation and produces right-sided heart failure. Pulmonary stenosis is usually congenital and is best treated with balloon valvuloplasty when severe. Pulmonary regurgitation commonly results from pulmonary hypertension or repaired congenital heart disease with surgery, reserved for advanced symptomatic cases. Understanding these four right-sided valvular lesions is important because they frequently occur secondary to pulmonary hypertension, congenital heart disease, or left-sided valvular disease. And early recognition helps prevent progression to irreversible right ventricular dysfunction. Now we will discuss mitral valve prolapse, or MVP, one of the most common valvular abnormalities encountered in clinical practice. We'll cover its etiology, pathophysiology, clinical presentation, diagnosis, treatment, and finally review the hemodynamic figures at the bottom of the page illustrating aortic stenosis, aortic regurgitation, and acute mitral regurgitation. Mitral valve prolapse. Etiology. Let's begin with the causes of mitral valve prolapse. The most common cause is myxomatous degeneration of mitral valve, where the valve leaflets become thickened, redundant, and bulky. The chordate tendinae also becomes elongated and weakened. Mitral valve prolapse is frequently associated with the connective tissue disorders such as Marfan syndrome, Ehlers-Danlos syndrome, pectus excavatum, straight back syndrome, and other musculoskeletal abnormalities. Approximately 3% of the general population has MVP. Another mechanism is prolapse of one or both mitral valve leaflets into the left atrium during the systole. This is an uncommon cause of mitral regurgitation and includes conditions such as click murmur syndrome, Barlow syndrome, floppy mitral valve syndrome. Physiology. The underlying abnormality is displacement of the mitral valve into the left atrium during ventricular systole. Although many patients remain asymptomatic, the prolapsing valve may produce complications including progressive mitral regurgitation, infective endocarditis, cerebrovascular events, and rarely sudden cardiac death. Symptoms. Many patients are discovered incidentally and remain completely asymptomatic. When symptoms occur, they may include atypical or stabbing chest pain, palpitations, fatigue, dyspnea, anxiety or panic-like attacks, exercise intolerance, pre-syncope or syncope, and orthostatic symptoms due to low blood pressure. These symptoms often do not correlate with the severity of mitral regurgitation. Physical examination. The hallmark finding is on auscultation. The classic finding is a mid-systolic click, which occurs because sudden tension develops in the prolapsing mitral leaflet and chordate tendinae. This click is followed by a late systolic murmur at the cardiac apex due to mitral regurgitation. Dynamic maneuvers change these findings. Standing or performing the Valsalva maneuver decreases left ventricular volume, causing the click and murmur to occur earlier and become louder. Squatting increases ventricular volume, delaying the click and reducing murmur intensity. These dynamic changes are highly characteristic of mitral valve prolapse. Investigations. Diagnosis begins with the electrocardiogram. The ECG may be completely normal. Possible Abnormalities include non-specific SDT wave changes, premature ventricular contractions, paroxysmal supraventricular tachycardia, and ventricular ectopy. Echocardiography. Echocardiography is the diagnostic test of choice. It demonstrates systolic displacement of one or both mitral leaflets into the left atrium, assessment of leaflet thickness, and presence and severity of mitral regurgitation. Cardiac catheterization. Cardiac catheterization or left ventriculography is reserved when clinical findings and echocardiography disagrees, or when mitral valve prolapse is discovered incidentally during invasive studies. Treatment. Asymptomatic patients, most of asymptomatic patients require reassurance rather than treatment. If mitral regurgitation is present, clinical follow-up should occur annually. If no mitral regurgitation exists, follow-up every 3 to 5 years is generally sufficient. Medical therapy. Patients with sinus rhythm who have a high risk of embolic event may receive aspirin. Anticoagulation is recommended for patients who develop atrial fibrillation, ischemic stroke, recurrent transient ischemic attacks, systemic embolism. Patients experiencing significant palpitations should avoid stimulants such as caffeine and receive beta blockers when appropriate. Surgical options. Surgery is indicated when significant mitral regurgitation develops. Whenever feasible, mitral valve repair is preferred over valve replacement because it preserves ventricular function and has superior long-term outcomes. Transcatheter mitral valve repair may be considered for patients who are poor surgical candidates because of high operative risk. Hemodynamic figures. Now let's examine the 3 important pressure tracing shown at the bottom of the page. Figure 49, hemodynamics of aortic stenosis. In aortic stenosis, obstruction at the aortic valve creates a large pressure gradient between the left ventricle and the aorta during systole. Notice, left ventricular systolic pressure rises dramatically. Aortic pressure increases much less because blood cannot easily cross the narrowed valve. This pressure gradient is the hallmark of severe aortic stenosis. On auscultation, this produces a crescendo-decrescendo systolic ejection murmur. Reduced mobility of the valve causes diminished intensity of the aortic component of the second heart sound, making S2 softer. And figure 50 shows hemodynamics of aortic regurgitation. In aortic regurgitation, the incompetent aortic valve allows blood to flow back into the left ventricle during diastole. The tracing demonstrates rapid fall in aortic diastolic pressure, wide pulse pressure, and progressive increase in left ventricular and diastolic volume due to regurgitation. Clinically, this produces an early diastolic decrescendo murmur immediately after S2 and volume overload of the left ventricle, leading to eccentric hypertrophy. Figure 51 shows hemodynamics of acute mitral regurgitation. This final figure illustrates acute mitral regurgitation. During ventricular systole, blood regurgitates from the left ventricle into the left atrium through the incompetent mitral valve. Notice several important findings. A prominent Left atrial V wave develops because the left atrium fills rapidly under high pressure. Left ventricular stroke volume decreases, left atrial pressure rises abruptly, and pulmonary venous pressure also rises, often producing acute pulmonary edema. The murmur is holosystolic, begins immediately after S1, and continues until S2. Unlike chronic mitral regurgitation, acute MR does not allow time for left atrial adaptation, making patients prone to rapid hemodynamic deterioration and cardiogenic shock. To summarize this page, mitral valve prolapse is usually caused by myxomatous degeneration and is the most common causes of mitral regurgitation in otherwise healthy patients. The classic physical finding is a mid-systolic click followed by a late systolic murmur, both of which change with maneuvers such as standing, valsalva, and squatting. Echocardiography is the diagnostic investigation of choice. Most patients require only reassurance, while severe mitral regurgitation is treated with mitral valve repair whenever possible. The hemodynamic figures highlight three important pressure patterns: aortic stenosis, large LV to aorta, systolic pressure gradient, aortic regurgitation, a rapid fall in aortic diastole pressure with volume overload of the left ventricle, acute mitral regurgitation, marked left atrial V wave with elevated left atrial pressure leading to acute pulmonary congestion. This completes our discussion of the mitral valve prolapse and the accompanying hemodynamic changes in valvular heart disease illustrated on this page. So, thank you for attending this lecture. If you're new to the channel, don't forget to like and subscribe. And see you in the next lectures.